Well, thank you, Natarajan, first of all, for inviting me for this lovely session of yours. And basically, I'm going to stick in this session on management of cataract surgery for the traumatic patients. Can we have these lights off, please? This particular case was a top cop in Tamil Nadu. And he was playing some badminton or something. His partner hit him. And you can see the lens had subluxated. Now what I'm going to show you is the mistake I'm making. I realize obviously I'll have to go in for a glued intraocular lens surgery in this case. So I'm just now deciding how do I go ahead and make my scleral flaps. Always remember, even if you're a retina person, one of the biggest advantages will be because you already know your vitrectomy is so good, it make life very easy to do glued IOL. I go for a vertical glued IOL. I always use chandelier illumination in these cases if I'm doing a posterior segment case. Now you notice here, I'm doing my vitrectomy and I have brought my nucleus up anteriorly. Now see the mistake which I have done. One, I should have converted it to an extra cap or an SICS and made my life easier. The second thing is, I could have done a scaffold technique and made my life easier. But what I've done is, I've tried to emulsify this nucleus without any support present. This is the biggest mistake you can do, and this is why I'm showing you this video, so that you learn what not to do. And you can see immediately the nucleus has gone down again. Now once the nucleus has gone down again, I'm going back again to pick it up. A technique in 1989 I started called Favit. Subsequently it has been modified better and better, and we call it as sleeveless phaco-tip assisted levitation or SPAL, which is getting published in the British Journal of Ophthalmology now. And you can see, using the bare phaco needle, you can just embed it inside, bring it up anteriorly and above the iris. Now once I have brought the nucleus above the iris, I will not make the same mistake again. So now the next step for me is to implant an intraocular lens above the iris. And you see me just doing that just now. What I'm going to do is I'm going to inject an intraocular lens above the iris slowly and steadily. Now what am I doing? I'm trying to create a scaffold appearance. This has been published in the Ophthalmology Journal in the December 2013 issue. Now, a little bit of viscoelastic to just protect the endothelium. The little bit of cortex which you can see floating the vitreous is not a problem at all. We can knock it off any time later on. But my first step is, if my pupil is good, I will put both the haptics above the iris. Now I have a scaffold or a temporary platform, and I can emulsify these nucleus fragments very comfortably. I'm using a gas forced infusion, so I get a deeper chamber than normal, so that I will not have any particular problem. Now once I have done this, now remember my nucleus is through. There's a little bit of cortex still posteriorly present there. But before I do that, I will like to convert this IOL into a glued IOL. So the same lens which is lying above the iris, you see now what I'm doing, I'm transplanting the same intraocular lens using this technique called the handshake technique. Using two hands with two forceps of glued IOL forceps, extending from one hand to the other till I reach the tip of the haptic. And you can see now the first haptic externalized. Remember, you can see the end illumination, chandelier illumination from the back. Now I go for the second haptic also. Again I catch the haptic anywhere you can catch it. Now go in from the sclerotomy flap. Again you can notice I'm going to now grab the tip of this haptic. Once I have caught the tip, I will externalize both the haptics. Now once both the haptics are externalized, the next step is to tuck these haptics inside. So you can see I'm doing a little bit of vitrectomy in the sclerotomy site. I use a 26 gauge needle for this. Create this Gabor-Charrier tunnel, tuck the haptics in. Now my next step is to work for the cortex which is present there. So I'm just removing this cortex. Once I have removed the cortex, then I know I'm comfortable. Push in air in the chamber. Now I will apply glue inside. You don't need fluid at this stage because you need the area to be dry. Apply the glue, seal it, and you have combined basically a SPAL, scaffold, and a glued IOL technique. And this is our same patient 2 weeks post-op, how this patient behaved. Saying that, the last clipping which I thought I'll show you quickly is another case which had a trauma, and because of the trauma the patient had developed a cataract, and the surgeon had implanted an PCIOL in the AC. So from the trauma the patient now developed a bullous keratopathy. So you can see when you get a trauma and you have not managed the cataract surgery properly, you can see the patient has developed a bullous keratopathy here. Now in such cases the question comes, how do you manage these cases? This is the latest technique which we have just started. It is called PDEC, or pre-desmosed endothelial keratoplasty, in which I am taking a 30 gauge needle, and you can see I am just injecting a bubble between the duas and the stroma. This separates the endothelium, the desmos and the dua layer from the rest of the stroma. If by chance you don't have enough bubble formation, you can also inject viscoelastic, as you can see now, creating this bubble. Now I can make a trephine and excise this PDEC lenticule. The advantage with this comes is you can do this at any age donor eye. In other words, you can do it even in a 1-year-old donor eye, whereas a DMEC graft you cannot do unless the donor is above 50. Now we have to attack the patient who had the trauma and the bullous keratopathy with it. So again I am now going to create the scleral flaps, and for short of time I will just show what I am doing here. You can see this PCIOL in the ACD which the surgeon has implanted. I am converting it into a PCIOL in the PC. Remember, this is a one-piece non-foldable IOL. So these are tricky lenses to do like this because they can then break. So once I have done that, I got one haptic out. I will then do the second haptic. You can see again with the handshake maneuver, but remember this is a single piece non-foldable IOL. Once I have got both of them tucked inside, my next process is to tuck them into those tunnels, as you can see. Now this is just not enough because you need to do a pupilloplasty also. So what I'm going to do now is I'm going to suture up this iris, as you will see just now, and once I have done that, you will see I'm creating a round pupil. What happens in these cases is you need a good air tamponade inside to push the graft back into place. That's why I call this as takes two to tango when you're combining PDEC with glued IOL. Once I have done the pupilloplasty, I will now then take the graft. And here you can see I am now taking off the endothelium of this patient. Once I have taken off the endothelium, I am going to take the graft, the PDEC lenticule, inject it inside. Watch now what I am going to do is, for unrolling it, I use a simple endo-illuminator. You can see this trick. It's called endo-illuminator assisted PDEC, which is also going to come out soon in the JCRS journal. But the idea of this is it tells you which side is straight and which side is inverted. So you see the curl like this exactly, you know the graft is bang on track. Once I have done that, I will then inject the graft inside the anterior chamber, fix the graft back, and you can see a little bit of portion of the graft still not fixed. I have adjusted it in such a way that the whole graft is fixed. Now I take off the AC maintainer, apply the glue, and seal everything down. So this basically completes this case, which is a complicated case of trauma, and you can see this is how the patient looks at the end of surgery. Thank you very much, ladies and gentlemen, and once again, Natarajan, you make India proud.